Okay, this is Chapter 13, Neurologic Diseases and Conditions. This is Part 1. We're going to look at conditions of the brain and the nervous system. And there's only a few of these conditions that we're actually going to skip in this chapter, and you see those on this slide at this time. The degenerative disc disease. We're not going to go into details about headaches, migraines, trigeminal neuralgia, or Guillain-Barré syndrome. As usual, when you start a chapter in the pathology class, you want to review the normal anatomy. And your textbook does a really good job of reviewing some basics about the structures of the brain, the structures of the spinal cord, and the basics about the orderly function of the nervous system. There's an interesting picture. Figure 13-1, there's picture A of the brain, picture B of the spinal cord, and picture C of the neuroma, which is the actual nerve cell. And then on the next page, picture D is showing the cerebrum, the largest part of the brain, and the parts of the cerebrum that are responsible for certain actions or sensing certain things in the environment. You see the sensory cortex. You see the motor cortex, responsible for movement, Broca's speech area, Wernicke's area, auditory area, memory, visual area, intellect, and personality. And I'm pointing those out because as I teach about certain injuries of the brain, including traumatic injuries and injuries caused by blood clots, strokes, the signs and symptoms of the condition the person has is going to be dependent on what part of the brain is actually affected. Okay, a couple diagnostic procedures first. Angiography you've seen before, which is a record, it's an imaging procedure, a record of the vessels, and this is particularly the vessels of the cerebrum, of the largest part of the brain. Cerebral angiography is excellent for showing the blood vessels of the brain and showing if there's clots in the brain, vessels, or narrowed areas in the vessels. And there's CAT scan, which you've seen a reference to in other chapters. X-rays are used to compose a computerized cross-sectional picture specifically of the brain here as we talk about the nervous system or the spinal cord. Contrast material may be used to allow the structures of the brain to show up more clearly on the CAT scans. The picture to the left is a person kind of bending over, and you can see I guess it's the physician with the white gloves on and holding a very long needle, preparing to remove some spinal fluid for analysis. A lumbar puncture, sometimes called spinal tap, is performed inserting this long hollow needle into the cerebrospinal fluid space and withdrawing some fluid so that they can analyze the components of that fluid. And you'll see references in several conditions that I talk about to cerebrospinal fluid analysis. The other picture is showing a person that's ready to have an EEG performed. A record of the electrical activity of the brain will be made that is especially useful in diagnosing conditions like epilepsy. And again, I'll reference the EEG again later in the chapter. Okay, CVA. The first thing you see on the screen is a little emergency room sign. If a person thinks they may be having a stroke, they need to get to the nearest emergency room as quickly as they can. When the person has a stroke, a CVA, cerebrovascular accident, either a blood clot has caused a blockage in one of the cerebral vessels, or one of the cerebral vessels has ruptured and is hemorrhaging, and damage is occurring to the sensitive nerve cells of the brain. So the quicker the person gets to the correct treatment, the better the results can be. As far as the signs and symptoms, it's all about what area of the brain is affected by the stroke. I showed you the picture in your book that shows the different areas of the cerebrum that control different parts of the body. So the signs and symptoms a person has of a stroke depend on what portion of the brain is affected. Like dysphagia, having difficulty speaking, or dysphagia, having difficulty swallowing, impaired consciousness, the hemiparesis, paralysis on one side, dizziness, double vision, the diplopia. There's a variety of signs and symptoms of having a stroke. And again, it's all about the area of the brain that is affected. With the CVA, you can see the word cerebrovascular. The vessels are involved, the vessels of the cerebrum, and whatever damage there is to the blood vessels will affect the sensitive nerve cells and other nerve tissue of the brain. If we're talking about a stroke that results from a blood clot forming in one of these vessels, there's going to be ischemia. There's going to be a blockage of the blood flow to that particular part of the brain. And the nerve cells will die very quickly. If it's hemorrhage, again, hemorrhage, rupture of a vessel, blood's not going to get past that hemorrhage area through the blood vessel system to provide the nutrients to a particular part of the brain. Okay, so when you look at symptoms and signs, again, there's a variety according to what part is affected. Now, when you look under etiology, you find that strokes are usually due to atherosclerosis, the fatty material that builds up in the vessels. The stroke may be due to also hypertension, the blood pressure getting so high. There's other predisposing factors like certain blood disorders that make it more likely that the blood's going to clot when it doesn't need to. Certain arrhythmias like atrial fibrillation, where the heart is beating very quickly and irregularly. Blood clots may form inside the heart chambers and then move up the carotid arteries to the brain, and those blood clots stop in one of the little vessels of the brain, again causing a stroke. Rheumatic heart disease, because of the valvular damage, the person's more likely to form those little clots that move through the blood vessels. A person is predisposed to developing a stroke and the atherosclerosis because of high-fat diets, because of lack of exercise, because of smoking, obesity, and systemic diseases like diabetes mellitus. Now, it's very important, again, that the person get to the emergency room as quickly as possible if they think they've had a stroke. The emergency department personnel will evaluate the person and probably send them right away for some imaging of the brain, like a CAT scan or an MRI or angiography. There's three main types of strokes, and that's what they tell you under etiology. There's the cerebral thrombosis, which is a clot forming in the cerebral vessels. There's cerebral bleed, which is the hemorrhagic. And there's cerebral embolism, which is a clot that is traveling through the bloodstream. I mentioned a few minutes ago when a person has an arrhythmia where the heart rate is too fast and irregular, or they have rheumatic heart disease, some problem with the heart valves. When the blood is not moving through the heart properly, it's more likely for blood clots to form in the blood moving through the heart, and then the blood moves out of the heart through the aorta and up the carotid arteries to the brain, and one of those tiny clots may be carried out the aorta to the brain by way of the carotids. That's an embolic stroke, that the clot moved there from somewhere else and it stopped in one of the small vessels in the brain. So that's an embolic stroke. The thrombotic stroke is a blood clot that forms in the vessel, and the most common cause of the blood clot forming inside the cerebral vessel is atherosclerosis. And then the other type is the hemorrhagic, where there's bleeding. So when a person has a stroke, it's either hemorrhagic in that they're bleeding from some vessel in the brain, or they have a clot that is either completely or partially blocked, a cerebral artery, or we even consider strokes when they occur in the pre-cerebral arteries, those arteries leading to the brain like the carotids. When the artery is completely blocked, an infarction occurs. And infarction is actually death of the brain tissue. Infarction is death of any tissue, but we're talking about brain tissue here. The larger the area of infarction, the more serious damage the person has to their brain, and the more likely they have permanent neurological damage. Now, in your textbook, transient ischemic attack is listed as a separate subtitle in your chapter. But it's kind of hard to separate my description of what happens when a person has a CVA from the TIAs. Okay, TIA stands for transient ischemic attack. Warning signs of thrombotic CVAs. When a person is having a transient ischemic attack, they have a tiny blood clot that is formed in a very small area of the brain. And it's probably so small that they'll have some very transient symptoms that will kind of come and go, which may include weakness of one side or numbness down one side, a little bit of dizziness, some difficulty swallowing or difficulty speaking, the dysphagia and dysphagia, confusion. The thing about the TIAs is that they come and go. Now, the person recognizes that something is just not right. And a lot of times people won't get treatment for the TIAs because they start feeling better really soon. The numbness goes away. Any symptoms that they have kind of go away again. The person definitely needs to be evaluated when they have any of the signs that they may be having a TIA, because the TIAs are warning signs that they're having these little tiny strokes and that they're very likely to have a larger stroke if they don't get some kind of treatment. The treatment for the TIAs will depend on the patient and the cause, but most likely the TIAs are due to the little blood clots that are forming, and some form of anticoagulant medication can be given to prevent the larger blood clots from forming. The danger with the TIAs is that they will progress on and eventually the person will have a major stroke. With the major stroke, the clot completely blocks an artery and infarction occurs. The angiogram will show that area of blockage, and the MRIs will show those areas of infarction, even CAT scans. All right, the embolic CVA again. The blood clot, or it may be a little piece of fatty material, like atherosclerotic material, flows through the bloodstream and makes its way up the carotids and into the cerebral arteries. Or maybe it doesn't even make its way to the cerebral, it stops in the carotids. That'd be a pretty large clot that stopped in the carotid though. The embolic CVA occurs very suddenly. It's not usually warning signs of the embolic CVA. The hemorrhagic CVA is also pretty sudden. In older patients, usually due to advanced age, atherosclerosis, and hypertension. In younger patients, the hemorrhagic CVA is usually due to some type of trauma or an aneurysm that ruptures. It may be a very small hemorrhagic CVA, the blood may be reabsorbed, good recovery of the patient, but the larger hemorrhages are often fatal. Signs and symptoms of the hemorrhagic CVA usually begin abruptly. Okay, when we talk about these symptoms occurring very abruptly, the person will have a sudden severe headache, and usually followed by some neurological deficit, usually on just one side of the body. Because if the stroke occurs on the right side, the left side of the body is affected. Stroke occurs on the left side of the brain, the right side of the body is affected. Like with hemiparesis, the person may have dysphagia, again, just difficulty forming words or speaking, changing pupils. It may be so severe that they go into an immediate coma. Not so common, but can happen. They may just experience nausea and vomiting after severe headache, delirium, seizures. Again, there's a number of different signs and symptoms depending on the area of the brain that is damaged by the ruptured cerebral artery. The really important part of this is that the other type strokes, the embolic and the thrombotic, are treated with anticoagulants or antiplatelet agents. If it's a hemorrhagic CVA, you'd never want to give a person anticoagulants or antiplatelet agents that are actively bleeding. So when I talk about treatment as is the same as for other strokes, I'm talking about treatment like the immediate medical intervention, the immediate use of the IVs or support with oxygen, immediate care, but not anticoagulants or antiplatelet drugs. Okay, here's some of the immediate treatments. Of course, if the person's comatose, the airway has to be maintained, oxygen, IV fluids. The thrombotic and embolic CVA treatment involves the use of antiplatelet or anticoagulant drugs like Coumadin that I've named here. Treatment of TIAs, control of risk factors. That's the smoking, control of the diabetes, losing weight, exercising more. Endarterectomy may be necessary where the blood vessel fatty material that's built up inside of it may actually be kind of, I'll use the word scraped out, removed, endarterectomy. And then again with the TIAs, some antiplatelet or anticoagulant therapy may be used, like even just aspirin therapy. Aspirin's a widely used antiplatelet drug. Treatment and rehab must begin as soon as possible after the onset of the CVA. And when we're talking about rehab, this involves our occupational therapy assistant students and our physical therapy assistant students, that after a person's had a stroke, they may be very discouraged because they've lost the ability to speak or the ability to use their arm or walk or whatever it may be. So the treatment rehab needs to begin as soon as possible and includes encouragement and just really helping the person understand that they can get better, because most people can. It may be a long rehab process, but if they're treated soon enough and treated correctly, they should be able to recover from the stroke. The first things to concentrate are on just activities of daily living, helping the person to just be able to feed themselves and dress themselves and take care of the very basic of needs. Okay, now looking at head trauma and hematomas. A hematoma is a collection of blood. So if we're talking about a hematoma on the brain, it may be an epidural hematoma, epidural collection of blood that forms between the skull and the dura mater. You may need to go back and review the anatomy again around the brain and the different layers there of the meninges, like the dura mater, the subarachnoid, and the pia mater. This is the epidural. This is when a hematoma forms between the dura mater and the skull. The subdural hematoma, the collection of blood is between the dura mater and the arachnoid membrane. Signs and symptoms are going to be similar. You know, we're talking about trauma. The person's head is going to be aching. They're going to have a headache, dilated pupils, nausea, vomiting, being very drowsy, possibly even losing the use of one side of their body. The signs and symptoms, again, are about the same because we're talking about these hematomas, these collections of blood that have formed and put pressure on the delicate brain tissue. The symptoms of the epidural hematoma usually appear within just a few hours of the injury. The symptoms of the subdural hematoma may be a little delayed. It's been known to happen that when the person's suffering from a subdural hematoma, they'll not immediately have those signs and symptoms, but a few hours later, once the blood has really started collecting and putting pressure on the brain tissue, they start having those signs and symptoms. There's a slower accumulation of blood with the subdural hematomas. Craniotomy may be necessary, which is to make an incision into the skull so that the pressure of that building hematoma can be released so it doesn't continue to put the pressure on the brain and increase the intracranial pressure, the pressure inside the skull. As far as causes of these hematomas, it's usually just getting hit in the head, whether it's in a car accident or other type of motor vehicle accident, or someone hitting them in the head with a bat or something. The patient may very well lose consciousness with these hematomas, with the intracranial injuries. All right, other forms of head trauma, the cerebral concussion. The person may have immediate loss of consciousness, but it's short-lived loss of consciousness. And again, it may be because of a car wreck hitting their head really hard, or that they got hit in the head with some object, but it's a very temporary brain dysfunction. Cerebral concussion is a possible bruising of the cerebral tissue caused by back and forth movement of the head, as in acceleration, deceleration, insult. Like a car wreck where you're traveling along at 60 miles per hour, you hit something that's standing still, and that's it, acceleration, deceleration. Patients, again, referred to as being knocked out, losing consciousness, maybe even have a little amnesia for the event. Treatment is usually just bed rest. It is important to check the person often when they have had a concussion to make sure that they're not developing signs and symptoms of that subdural hematoma that I mentioned a few minutes ago that has delayed signs and symptoms. The contusion, with the contusion, it's more serious than the concussion. Bruising of the brain tissue with symptoms and signs lasting more than 24 hours. Again, usually some blunt object impact or car accident. The injury is more severe, more lasting effects. Treatment, again, the special monitoring to be sure that the intracranial pressure does not increase from a delayed accumulation of blood from a subdural hematoma or epidural hematoma. Okay, more head trauma. The depressed skull fracture. You know about fractures, a break in the bone. The broken part of the skull actually is pushed in on the brain. The skull bones are depressed or torn loose so that they're pushed below the normal surface of the skull. Symptoms depend on the site. Craniotomy is usually going to have to be performed to relieve the intracranial pressure. When we look in the book, the signs and symptoms, maybe the hemiplegia. maybe seizures because of the depressed skull fracture. And at the same time, I want to talk about the basilar skull fractures that are described under the enrichment. Basilar skull fracture, fracture of the bones of the floor of the cranial vault. Oftentimes the sign that's seen are what's called the raccoon eyes, or the battle signs, where the person has very, very dark circles under their eyes because, following a head injury. They may have leakage of cerebrospinal fluid from the nose or from the ear. Treatment is the normal treatment for head injuries with observation and possible craniotomy again. Maybe having to do surgery on the brain to relieve pressure. Under the spinal cord injuries, there's a number of different causes of spinal cord injury. If we're talking about a traumatic spinal cord injury, usually the vertebrae will also be broken. There'll be a fracture of vertebrae that goes along with the injury to the spinal cord. And the signs and symptoms a person has, or the damage that they suffer from, depends on what level of the spinal cord is damaged. What you're seeing in this picture is a red line here that shows a spinal cord injury above this line would result in quadriplegia, which would be paralysis of all four extremities. An injury below that line would result in some form of paraplegia, the paralysis of the lower limbs of the body. And depending on what level the person, if it's a very low injury, they may just have difficulty moving their legs or feeling their legs, paralysis of the legs. The higher the level of the spinal cord injury, the more likely they are to have more loss of function, such as loss of bowel and bladder control, loss of sexual function, again, depending on how far up the actual injury occurs. Quadriplegia is loss of motor and sensory control of both the lower extremities, the trunk, and either partial or complete paralysis of the upper extremities. When you look in your book, there's pictures of different ways that spinal cord injuries occur, with compression of vertebrae or hyperflexion of the neck, like in a car accident where the head's thrown forward at a very high rate of speed, or in the hyperextension of the spine where the person, probably what we refer to, they break their neck, maybe diving into water that's very shallow, or in some way slamming their head backwards, the hyperextension of the spine. Either one is bad. The hyperflexion of the neck or hyperextension of the spine can result in a ripping or tearing of the spinal cord. When we look at treatment, the treatment's all about trying to restore normal alignment and stability of the spine itself, decompression of spinal cord nerves, early rehabilitation of the patient. It's so important to get them in rehab as soon as possible, and that's again where the physical therapy assistants come in. The earlier the treatment's begun, the better the prognosis. Okay, let's turn over a couple pages to herniated intervertebral disc. And the title in your book is Herniated and Bulging Disc. And what we're talking about here is what's formerly known as a herniated nucleus pulposus. It's really important that you know that abbreviation and know what the abbreviation is referring to. HNP, herniated nucleus pulposus. This is a disc. Well, this is the vertebrae, this is the bone part of it, and this is the disc. And in the center of the disc is a very thick jelly-like material. We'll go with jelly-like term. It provides kind of a cushion there in the disc. It's called the nucleus pulposus. When the nucleus pulposus herniates out of its normal area, it will put pressure on these spinal nerve roots. And the pressure on the spinal nerve roots can be unbearable with the pain that is created. The pain that a person has will depend on what level of the disc is involved. If it's a herniated nucleus pulposus of the lumbar area, the person's lower limbs and lower back will be affected, and that's where that most commonly occurs, the lower back. If the herniated nucleus pulposus is in the cervical spine area, then the neck's going to be involved and the pain will radiate down an arm. Sciatica, which I'll be talking about in detail in one of the next slides. When a person has a herniated nucleus pulposus, it might put pressure on the sciatic nerve, which causes the radiating pain down a leg, usually just down one leg. Treatment for the herniated nucleus pulposus, the HNP, there's a variety of levels from the very most conservative of bed rest and physical therapy and non-steroid anti-analgesics, and then we move up the level. The person may receive epidural injections for the pain caused, or to try to reduce the inflammation with steroids. There's also surgery that can be performed to try to relieve the pressure from that herniated disc. Okay, here's the sciatic nerve injury that could be due to the rupture of the herniated pulposus, could be due to trauma or just a degenerative process. You see the position of the sciatic nerve shown in the diagram on our slide. Pressure on that sciatic nerve will cause severe, sharp pain to radiate down the leg and the foot. When the person experiences this pain, they need to be examined. It needs to be determined, evaluated, what's causing the sciatica, what causes that pain. It may be a temporary damage or it may be a permanent damage. Treatment again ranges from the very most conservative with bed rest and physical therapy to surgery and drug therapy with steroids. These are some of the widely used drugs that are used for analgesics, whether we're talking about sciatic nerve pain or degenerative disc pain. Non-steroid anti-inflammatory drugs like generic names ibuprofen, some of the brand names Motrin, Advil, Nuprin. There's also Naproxen brand name, which is a naproxen generic. Okay, now let's look at epilepsy. Skipping over a couple conditions here in your textbook to epilepsy. A recurrent disorder of cerebral function characterized by sudden, brief attacks of altered consciousness, motor activity, or sensory phenomena. Convulsive seizures are the most common form of the attacks. The important thing here is that they're recurrent attacks. There's an area of the brain that is affected that will cause the person to have these attacks. Now, they may be very, what appear to be very mild, called petit mal seizures, where the person just appears to be just staring off in space, or they may be the more severe convulsive seizures. A lot of different causes for the seizures. Injuries to the brain, birth trauma, skull fractures, tumors can cause epilepsy, alcoholism, certain drugs can cause epilepsy. The epilepsy may be idiopathic, and they cannot determine what the reason for having epilepsy is in a particular patient. A person may or may not have what's referred to as an aura, which is a warning sign that signals an impending seizure. People who have had these auras describe it sometimes as just a feeling that can't really be described in words, or they smell a particular smell, or they see flashing lights, but they have some warning that they're about to have a seizure. They can't stop from having a seizure, but there are times that they can know to at least sit down so they don't fall so far to the ground having those grand mal seizures. I mentioned the petit mal a few minutes ago versus the grand mal. Petit mal consists of brief change of level of consciousness, staring or just blinking, just seem to not be at all, not just seem to, but they are not aware of their surroundings. In the grand mal seizures, this really involves the person falling to the ground and having the violent shaking and thrashing movements that you probably associate more with convulsions, with true seizures. And it can also result in contractions of respiratory muscles and cause the person to turn blue with cyanosis because they're not getting oxygen to their tissues. Another term to know about in reference to epilepsy is the term status epilepticus. When a person has status epilepticus, it's also referred to as intractable epilepsy. They do not respond to the anticonvulsive medications. They have one seizure after another with no recovery of consciousness between the attacks. So the medications don't work for them. They have one seizure after another. Diagnosis and treatment. After the patient or someone with them describes the seizure, the physician should go on to have an EEG performed, the electroencephalography, to show the brain waves. The most common medications, anticonvulsant drugs like Dilantin, like Tegretol, mycilin, should be capitalized then there. The generic drugs are not capitalized. The brand names are capitalized. I have to fix that. I can't let that go on without fixing it. It should be a capital M for the brand name. Sorry about that. Just had to fix it because I knew it was wrong. Okay, these are names of anticonvulsant drugs that are commonly used in epilepsy treatment, but there are many others too. There's many anticonvulsant drugs available now. And now Parkinson's disease. Degeneration of nerves in the motor system of the brainstem. Usually occurs later in life. Now there are some cases that have occurred in 30-year-old people. Probably the most famous of them would be the occurrence of Parkinson's in Michael J. Fox, an actor who really cannot carry on the acting anymore because of the shaking that goes along with Parkinson's. Very distinctive tremor. When a person is first realizing there's something wrong and they're in the earliest stages of Parkinson's, they literally slow down in movement, called bradykinesia. Brady's slowing, kinesia's movement. And then as it progresses, they develop tremors and rigidity. As it progresses, the problem here is a deficiency of dopamine. Dopamine is a neurotransmitter, and it's absolutely necessary for us to have correct movements and purposeful movements. These deficiency of dopamine, studies have been done, but the direct cause is really not known. There are some really good theories out there. They see cases of Parkinson's that seem to run in families, so they believe that there is an genetic predisposition to it. Parkinson's can also occur after poisonings with certain substances. There's certain drugs also that can give the appearance of someone developing Parkinson's. After someone has encephalitis, inflammation of the brain from a viral disease, they may develop the Parkinson's. Now there's medications that can be used to treat the Parkinson's, but there's really no cure, and the medications they use don't work forever. They may take the levodopa for a while and have a relief of the signs and symptoms, but then eventually the signs and symptoms come back again. Antidepressants are commonly used. It's really important, if you're the physical therapy assistant who's treating a patient with Parkinson's, be sure the patient has received their medications at least 30 minutes before the physical therapy, so that you can have the maximum results of the therapy. Huntington's chorea. All right, this is truly an inherited degenerative disease of the nervous system. It affects the cerebrum, and the person with Huntington's chorea develops these bizarre movements. It's called St. Vitus dance because of the dance-like movement. It's not dance-like. They're just involuntarily kicking their legs out one direction or another, or their arms one direction or another, and it's pretty much continuously. At first, the person just appears to be just fidgeting, have some mild kind of tics or tongue smacking. Then they start developing difficulties with their speech, and then unfortunately they start developing dementia to go along with this. Their personality changes. They begin to use very poor judgment and carelessness, impaired memory, very sad progression of the disease. Usually starts in middle age and then progresses. Treatment, it's not real good treatment for the Huntington's chorea because it is an inherited condition. The person with the Huntington's chorea is just going to have supportive treatment. Treatment to protect themselves when they have these bizarre movements. Medications to use just to kind of keep them calm and to help with the dementia, help with the agitation. Interesting statistic, anyone born into a family with Huntington's disease has a 50-50 chance of survival. They'll develop 50-50 chance of developing the disease and then surviving into old age because of the effects of the Huntington's chorea. Amyotrophic lateral sclerosis, abbreviated ALS, also known as Lou Gehrig's disease. In Lou Gehrig's disease, this amyotrophic lateral sclerosis, there's degeneration of nerve cells connected to the brain that control the voluntary motor functions. Amyotrophic lateral sclerosis. I'll go back to that screen because I know I went pretty quick there. Also called Lou Gehrig's. They have degeneration of motor neurons in the spinal cord and the brainstem. Results in muscular atrophy. The muscles just deteriorate because they're not getting any stimulation from the nerve cells. Signs and symptoms include weakness in skeletal muscles, difficulty at first in speaking, swallowing. They'll develop dyspnea because the respiratory muscles become involved. Slightly more common in men than women, and unfortunately the treatment is only supportive, just trying to support the person as far as the respiratory problems they have. Uncertain etiology, some question about some inheritance pattern there. Death usually follows within 6 to 10 years after the diagnosis because of that pulmonary involvement. Peripheral neuritis. Inflammation and degeneration of peripheral nerves affects the distal muscles of the extremities, the hands, the feet. At first it appears to just be a clumsiness. Eventually they lose sensation in their hands and feet. Look at some of the etiologies. Chronic alcohol intoxication, toxicity from arsenic or poisonings, lead poisoning. Metabolic and inflammatory diseases like diabetes mellitus, rheumatoid arthritis, gout, and lupus. Nutritional deficiencies may also result in the peripheral neuritis. So the treatment for peripheral neuritis depends on the cause, focusing on that underlying cause. Supportive measures like antidepressants, physical therapy, anticonvulsants if convulsions are present. Bell's palsy, unilateral facial paralysis, paralysis on one side of the face. May be transient, may come and go, or it may be permanent. We've seen cases of Bell's palsy in pregnant people that after delivery of the baby, they no longer have Bell's palsy. We've seen temporary Bell's palsy, and then we've seen permanent Bell's palsy due to some injury to the facial nerves. Early treatment's very important. Recommendations here, massage, warm, moist heat, facial exercises, steroid anti-inflammatory drugs like prednisone are sometimes helpful. Full recovery depends on what the initial cause of the Bell's palsy is and how much nerve damage is present. Meningitis. This is showing a pretty severe case of meningitis. The person has severe headaches, fever, nuchal rigidity. They can't hardly bend their neck. This person's got a very advanced case of meningitis where they're assisting him even laying down on the exam bed. Photophobia. Looks like fear of photos, but it's not. Photophobia is a fear or sensitivity to light, not a fear of. It's an extreme sensitivity to the bright lights. Severe headache, again fever. If meningitis is suspected, which is the inflammation of the membranes covering the brain and spinal cord, it's very important that the person receive evaluation and treatment right away to determine if meningitis is actually present. It's confirmed by a cerebrospinal fluid analysis with the fluid obtained by the lumbar puncture that I mentioned a few minutes ago. I've listed some of the most common organisms causing meningitis on the screen. But meningitis can be either bacterial or viral. The bacterial at least can be treated with antibiotics. The viral is more just a supportive treatment. Either one is bad. We're talking about inflammation of the membrane surrounding the brain and spinal cord. I want you to look also under, let me back up, under the etiology of the meningitis. The infection can originate directly in the brain or spinal cord or in the sinuses. Open head injuries are additional portals of entry. So a person that has a sinus infection, chronic, that they just can't get rid of, it may actually spread from the sinuses to the meninges. Aggressive treatment is necessary to prevent long-term complications. Now, inflammation of brain tissue, direct inflammation of brain tissue is the encephalitis. Again, same type signs and symptoms: headache, fever, stiff neck and back, muscular weakness, visual disturbances. Etiology is most likely viral. There are viruses that follow chickenpox, measles, mumps that can result in encephalitis. There are cases of encephalitis that are known to have been mosquito-borne. Mosquitoes will carry the virus, infect the person, and the encephalitis develops. Again, these cerebrospinal fluid studies will confirm the diagnosis. Treatment is supportive treatment, analgesics, the antipyretics to keep the fever down, the anticonvulsants to decrease the likelihood of seizures. Next is the description of brain abscess, which is a collection of pus in the brain tissue. Pus is caused by bacterial infection. Now, the infection could originate in the brain, or again, the infection could be carried to the brain from an infection of the sinus, of the ears, of an abscessed tooth. So it's just very important that infection anywhere in the body is completely treated with antibiotics so it doesn't spread to a place like the brain. CAT scans are used to confirm the diagnosis because they'll show that area of abscess of the brain. Sometimes the aggressive antibiotic treatment will be enough. Sometimes the person may have to have surgery to remove the abscess. Important note here about the lumbar puncture. I mentioned how important the lumbar puncture is to diagnosing certain conditions by analyzing the cerebrospinal fluid. But if the person has a brain abscess, or for that matter, any condition that causes an increase in intracranial pressure, pressure inside the skull, if they have a lumbar puncture performed, the lumbar puncture may actually cause herniation of the brainstem and death. Very, very important that the person have the correct neurological exams and imaging exams before the lumbar puncture is performed. Treatment again, the IV antibiotics, steroids to reduce the inflammation, and maybe even surgical drainage. The video showing here is showing someone walking with braces on their legs and assistance because of poliomyelitis, the long-term effects of polio. When a person has poliomyelitis, there's inflammation of the gray matter of the spinal cord. It's a viral infection, and thank goodness in the United States anyway, poliomyelitis has nearly been eradicated through vaccinations. It's so important to continue to have children vaccinated against polio. Look at some of the signs and symptoms. Profuse rhinorrhea, a runny nose, malaise, muscle weakness, stiff neck, nausea, vomiting, could be signs and symptoms of a lot of different conditions, but if the patient has not been vaccinated, the doctor has to suspect polio. They end up developing this flaccid paralysis of the muscles involved. I want you to look under etiology of the poliomyelitis. Enters the body through the nose and throat, crosses into the GI tract, traveling by way of the bloodstream, the virus progresses to the central nervous system. Incubation period is usually 7 to 21 days. It's transmitted from person to person by infected oropharyngeal secretions or feces that may contain the virus. Treatment is supportive because once they get this virus, supportive treatment can be given in hopes that they're going to survive the poliomyelitis. Very likely they'll survive the polio, but it's the long-term effects of the polio that are such a problem. Look under treatment, the last paragraph under treatment. Post-polio syndrome occurs later in life in persons who have previously experienced the disease. Post-polio syndrome affects muscles. The muscles deteriorate, they have loss of strength, and this progressive muscle weakness begins 30 years or more after the initial infection with polio. Treatment again is just supportive. The important thing here is prevention of polio through the vaccinations. Okay, intracranial tumors. Anytime tumor is present, it could be benign, which is non-cancerous, or it could be malignant, which is cancerous. Anytime a person has a tumor of the brain, it's a problem because that growth is going to displace brain tissue. The malignant or the cancerous neoplasms, when I say they may be primary or secondary, if they're primary, they've originated in the brain, and they have a chance of spreading to somewhere else in the body. If the cancerous tumor is secondary, it means that the cancer originated somewhere else in the body and spread to the brain. Like the cancer may have originated in the lungs or the ovaries or the colon, and it spread to the brain to set up a secondary cancer. If a person has a primary tumor of the brain, primary tumors originate in neuroglial cells. Signs and symptoms depend on the site of the tumor. Again, I take you back to the very first picture that I showed you in the chapter that involves the different areas of the brain that control different parts of the body, even the specific area that controls personality. Signs and symptoms of the brain tumors depend on where the brain tumor is located. Treatment includes radiation and chemo, and if it's operable, surgery could be performed, maybe even a combination of surgery, radiation, and chemo. I want to add one more condition or at least one more. Multiple sclerosis that we talked about in an earlier chapter. Chronic progressive disease, idiopathic etiology, usually affects young adults and usually women between the ages of 20 and 40. The various early symptoms involve paresthesias of the limbs like the feet or the legs, tingling and numbness sensation, loss of balance and poor coordination. The multiple signs of the MS affect different parts of the central nervous system at different times. There may be times that the person has problems with their legs, and then those problems will get better, and then they find they can't see out of one eye, and then they regain their sight, and then they have a problem in a different area of the body. In multiple sclerosis, there is degeneration of the nerve tissue. There's destruction of the myelin sheath on the neurons. I've got a picture here that kind of looks like a little worm eating up the myelin sheath. It's not really a worm, but that was a good picture that I thought to describe that the cells, the body's own cells, attack the myelin, attack this protective insulation around our neurons. The myelin sheath is destroyed and then replaced with hardened tissue, thus the name sclerosis. No effective treatment, there's not a cure, just treatment supportive. Anti-inflammatory drugs are used, psychological counseling and physical therapy to help a person deal with the progressive multiple sclerosis. I want to talk about tetanus here too, also called lockjaw. Tetanus is one of those conditions that can be prevented with vaccinations, and it's not good enough just to have one vaccination. It takes a series of boosters throughout a person's life. It's caused by a particular bacteria, but usually by the time the person knows they have been infected, it's too late to have the correct antibiotic therapy to combat this bacillus. The organism will enter through a wound, and then it produces necrotic tissue and pus infection because of the bacteria, and then it progresses to form a poison that affects the motor nerve cells. And those motor nerve cells will stimulate muscles and cause contractions of the jaws, contractions of the back, as you see in this picture. Again, the prevention is so important. It's prevalent also in garden soil that's fertilized with horse manure, for instance. It's important to clean a wound with at least hydrogen peroxide and have vaccination boosters as often as recommended. First sign, stiffness of the jaw, the drawing of the esophageal muscles and neck muscles, and then the muscles of the back become involved, and then quickly the muscles of respiration will become involved, and the person will probably asphyxiate if they don't get the correct treatment fast enough. Usually, but not always, fatal. Adequate immunization is a booster shot every 10 years. But if a person is injured with a dirty wound that's likely to be infected, they can have an immunization within 5 years. Rabies I also want to include in this description of central nervous system condition. Infectious disease of the brain and spinal cord caused by a virus transmitted by saliva of infected animals. Again, the prevention is so important, and the prevention is having our animals vaccinated, our domestic animals vaccinated, and if we are bitten or scratched or come in contact with a wild animal, we might very well have to have rabies shots to prevent us from developing the true infection with rabies. The virus will enter at the site of the wound, and then it moves along the nerves of the central nervous system, and then causes an acute encephalitis. It's a slow acting. It takes 40 to 60 days, but if you wait long enough to start having the symptoms of having rabies, it's too late. It has to be treated right after the virus infects the body. Signs and symptoms: fever, pain, mental derangement, rage, convulsions, paralysis, spasms of the throat at the sight of water. Again, the disease is fatal once it reaches the central nervous system. If the anti-rabies injections can be given before it reaches the central nervous system, then there's hope for survival of the patient. Vaccination of domestic animals is so important. That concludes the lecture on the nervous system.